A very good evening to you. You're with Channel I and this is iMed. Usually on iMed we discuss various types of diseases when it comes to the human body and how it affects us as well. And we do invite an expert about a specific subject that we talk about on that day and have a very descriptive discussion on how you could alleviate, how you could diagnose and everything when it comes to a disease and its treatment. So we did talk about asthma last week and asthma and its related aspects. So today we will be continuing the discussion, and we did invite the consultant pulmonologist at the teaching hospital and district chest clinic in Ratnapura, Dr. Niranjan Disanayaka, to join with us in an attempt to educate the public about the disease of asthma. Now, we did have very big conversations, very descriptive conversations last week. Now, if you did not watch it, we have our YouTube channel, do check it out. And now, starting off the conversation with the current situation in the country, we are still inside a pandemic situation. I would say it's not that much restrictive, but still we do have the COVID-19 pandemic with us. There are still cases being identified. Now, what is the effect on an asthma patient if he or she has come across or contracted the COVID-19 virus? What are the research done on this?
Actually, we see a little bit of a different pathway when you consider COVID. Now, usually viral infections, when it affects the lung, especially in a person who is having a chronic lung disease, it affects detrimentally and it increases the exacerbations, the amount of hospitalizations and sometimes even death. But during the COVID pandemic, we actually, anecdotally actually, and even in the research, we don't see a significant amount of rise of asthma exacerbations as it should be. Probably because of the measures that we took for infection prevention and the wearing of the mask, as well as sometimes the treatment that was given for asthma. Now, some of the literature has shown that the drug budesonide, an inhaled steroid that we give for asthma, has a certain degree of protection from the COVID exacerbations, asthma exacerbations, and progression of COVID as well. So probably because of that, we didn't see a significant rise in our asthma patients coming into with exacerbations. But that doesn't mean that the risk doesn't exist. So if we have severe asthma, that means uncontrolled asthma, any viral infection, including COVID, can have the potential of causing fatal disease. So it is always important to control your asthma, whatever the current situation is.
Again, now COVID-19 again is a problem in the world, not just Sri Lanka. So now what are the challenges when it comes to, because COVID-19 was a severe hit to the country's economy and much more to the health sector as well. It was a big hit. So what were the challenges during this period and in the past as well? What were the challenges when treating asthma?
One of the major challenges that we faced was that, and the patients faced was that, especially because of the lockdowns, the transport difficulties, the people are not having the ability to come to the hospital to collect their treatment, and the restrictions to the investigations, because some of these investigations were not freely available, and those problems would have affected in a negative way for asthma patients. But some of these aspects we addressed actually. So we used to send the drugs, the inhalers and everything by post and deliver them to their homes so that they will take these drugs without stopping. And the transport we couldn't actually address, but by delivering them by post and the drugs being given to them, I think we were able to negate certain detrimental effects of asthma patients about the disease of during the COVID period. For asthma, specifically COVID, I don't think caused a significant amount of problem. But as in any chronic disease, the delivery of the medicines, sometimes some people have stopped the treatment during the COVID period, thinking that they don't need the treatment. So there are other issues like that, but I don't think it directly affected asthma care.
And now let's talk about, I think when we talk about challenges, there are challenges in the view or in the perception of the doctor. Say, for example, you overdiagnose a patient or you underdiagnose a patient, that can be really impactful when it comes to the asthma patient's health care.
Yes.
So what is your thoughts on that?
That's a really good question. Now, when you think about diagnosing of asthma, now unlike so if you have a disease, we'll say like diabetes, you have a cutoff point of below this you are not diabetic, above this you are diabetic. And if you have a heart attack, you will have ECG changes, you will have enzymes in your body that will be rising, and there will be changes in the heart that you can identify to say that you have heart disease. But in asthma, it's basically what we call a clinical diagnosis. Clinical diagnosis means you go according to the clinical history of the patient, and as you correctly said, that may yield, because it is non-specific, to underdiagnosis as well as overdiagnosis, and both are happening in the world. So for example, a person who is actually having asthma is not diagnosed as asthma and being treated, short-term treatment, and the patient is sent home, but the patient will continue to suffer long-term because of the asthma. And as as earlier said, the lung will gradually decline its function, and this child or adolescent or the adult will suffer psychologically as well as probably economically because of these asthma attacks. So there, I think we are at fault as a medical profession of underdiagnosing asthma and not giving the proper treatment that the patient needs. It happens at various levels, even in a major hospital it happens. And the second important thing is that the overdiagnosis. So all that visas is not asthma. As I told previously, anything that causes a narrowing of the airway or irritation of the airway can actually have trigger these symptoms. So there are many other diseases that can mimic asthma. We call it asthma mimics. So if you don't properly investigate these patients by taking a proper history examination, we might treat another disease as asthma. Sometimes it might be very detrimental to the patient because the patient is not getting the treatment that he should have. For example, this patient might have conditions like tuberculosis, where you can have a chronic infection in the lung, and actually tuberculosis is also completely treatable, but you are now treating for asthma, which has no effect on the tuberculosis outcome. Some people might have a cancer inside. That might be the reason that the patient is coughing, and he might be treated to another thing. And some people might have conditions like a simple reflux of the stomach coming in and going into the lung and causing cough, which is not asthma. You don't need an inhaler for that, right? So there are various other diseases that can mimic, especially in obese people. Sometimes because of their shortness of breath, they tend to be diagnosed of having asthma more frequently than others. Obese people have asthma than other people because of their body composition and other physiological factors, but some of them actually don't have asthma. They are overdiagnosed and overtreated, and that is the problem with that. So, and unfortunately, these two spectrums, underdiagnosis as well as sometimes overdiagnosis, has been found to be common in deprived communities. Right? They don't have in the communities who doesn't have a good education or doesn't have a good socioeconomic status. Those are the people, and females, those are the people who are actually underdiagnosed or overdiagnosed. So, but it can be prevented, and asthma can be managed in a proper way if we follow the correct pathway.
I think again there was some challenges. There are challenges when it comes to treating an asthma patient in the current context of the country as well. So now, doctor, there is this confusion, or I should say misconception, of these two diseases. Now, asthma and COPD, because we did discuss before the interview that people tend to mix up these two diseases. COPD, as you know, is chronic obstructive pulmonary disease, and asthma. So what is precisely the difference between the two, and if you could explain? And
the difference, I think that's a really good question, and the difference is that the treatment is completely different. The etiology is completely different. They can coexist together, asthma and COPD. We call it asthma COPD overlap, but it's two different diseases. Now, for example, asthma usually is common in the younger age groups, and it is actually a genetically predisposed disease, and it is most likely driven by allergic components, allergic derived components. There are other driving factors for asthma other than the allergic component. That is, there are different types, but basically it's majorly like that. But when you compare to, and the airway narrowing that we described in asthma is reversible. That is completely reversible. If it is properly treated, you can completely make the airway back to normal. And if you continue the treatment, it will be like that to your life without any deterioration, except for the normal deterioration of your lung function that happens yearly. But in COPD, actually, it is a response to inhaling noxious substances, bad substances to your lung. One of the major important substances is smoking, the constituents of smoke, and the air pollution, the diesel fumes and other fumes that are there in the environment, as well as in the indoor air pollution. Now in Sri Lanka, our women do not smoke actually. I think they are brighter than our males in that aspects. But basically, they are exposed to a lot of firewood and certain harmful substances that are used to burn and cook inside the kitchen. So they usually inhale these substances, it goes into your lungs and it damages the lung permanently. That is the problem. So this damage, after you inhale a certain substance, there will be a response from our body to that. We call it inflammation. And the damage as well as the response will cause permanent damages to the airway. And this airway will be permanently narrowed.
So it's irreversible?
It is irreversible. It is not completely reversible. So this is the major difference. This airway narrowing, we will not be able to get back to the normal state. So that is the main difference. And usually COPD we see above 45 years. Unlike in asthma, we see it in the whole age spectrum. So it is a disease of the elderly actually, because it takes some time to damage the lung due to the exposures. And the asthma is usually a younger, have a young predominance. That doesn't say that you can't have asthma when you are old. You can have asthma, but basically it's predominant there. So it's completely different. The way you treat is completely different. So for asthma, the mainstay of treatment is what we call steroids. But you should not give steroids to COPD patients because it can cause significant side effects without any benefit, except in a small group of people which where a certain cell is increased, or when you have asthma and COPD together, right? So in COPD, we usually give the bronchodilators. That means the drugs that we use to dilate air, the airways, and that should never be given to asthma patients alone. Now there we give bronchodilators without any problem, but if we give it to asthma patients alone, like salbutamol, that will increase the mortality of asthma patients. So completely different diseases.
I think a huge responsibility lies on the doctor as well to diagnose the disease properly. And talking about the age spectrum, doctor, now the different ways of response. Now there are different ways of response from kids to adults, to adolescent people, or to pregnant women when it comes to asthma. So what are these different, how does asthma affect to the pregnant women out there, if any patients are watching who are asthmatic and are pregnant, because asthma is prevalent in pregnancy.
Yes.
And also I have heard this, they actually stop the treatment if the patient has asthma and if they are in the stage of pregnancy. So what is your take on that?
I think that is a very important point that we have to discuss today. Pregnancy, every mother, every parent loves their child more than themselves actually. So what they usually do is, at the moment that they know that you are pregnant, they usually stop the treatment of asthma. And they usually stop taking any treatment. Their food habits and everything will change from there onwards. And what it does is that, and the science has found that usually when you have asthma and when you become pregnant, about 33% of the women will pregnancy will make asthma worse. That is a factor that makes asthma worse, right? And about 33%, 1 in 3, will not have any change. It will not worsen or it will not improve as well. There is a fortunate 1/3 who might have an asthma remission during pregnancy. That is, the asthma symptoms might go down a little bit. It is because of the physiological nature of our body. And we can't identify beforehand who will be improved and who will be deteriorated. That means 2 out of 3 will have asthma as a problem in pregnancy, right? So the problem with asthma in pregnancy is that when you have asthma in pregnancy, if you have asthma in pregnancy, the tendency to have small children, that means IUGR, that means intrauterine growth retardation, small children, the tendency to have births before the stipulated time, right? That means pre-labor, right? And sometimes even congenital abnormalities, and sometimes the maternal complications like pregnancy-induced hypertension, increased cesarean rates, increasing amount of hospitalizations. Everything is increased in patients with asthma. So there is a huge risk of asthma being not controlled during pregnancy. And not to mention that when you have an attack of asthma, when you have a severe attack of asthma, your oxygen level goes down in your body to a certain extent when you have a severe near-fatal attack. So when your oxygen level goes down in your body, the placenta blood supply will also be affected, and the oxygen level of the blood will go down in the placenta as well. Placenta will not give enough blood oxygen to the fetus, and the fetus can be damaged, sometimes permanently. And some of the investigations that we might have to do and the treatment that we might have to give to save the mother can be harmful to the fetus as well when an exacerbation happens, because when an exacerbation or severe asthma happens, we usually try to save the mother, right? And that is the main problem. So the most important thing is to prevent an exacerbation from happening while you are pregnant, and that's the most important thing. So whatever your treatment is, you have to consult a doctor, and then ideally you have to continue the treatment without stopping, because most of the preventers that we give for asthma, like the steroids, the budesonide, the beclomethasone, are considered harmless, and there are enough evidence even in the British Thoracic Society guidelines and the guidelines in the United Kingdom and as well as in the USA, developed countries. There are enough guidelines to say that it is safe in pregnancy. The risk is far more than the benefit. That means that yes. So risk is far less than the benefit that you get to the mother as well as child. So the message to our mothers is that, before now most of the pregnancies are planned, thankfully, right? So they plan their pregnancy. So before you think about getting pregnant, if you have asthma already, go to a good doctor and get it under control with proper medication. So after getting it under control with the proper medication, certainly you can become pregnant without any problem. And with the guidance of the doctor, continue the treatment properly and have a regular follow-up every 1 month or 2 months, or sometimes even 3 months. You can have a regular follow-up without problems. And there's another problem with pregnancy and asthma that I would like to highlight about overdiagnosis. In pregnant women, because the tummy comes up, it compresses the chest wall, and there are some changes in the hormones as well, and you are more breathless in pregnancy. That's a normal phenomenon. If you ask our mothers, our wives, I think they will tell us that you feel more breathless and tired during pregnancy, and that is a normal phenomenon. So you don't have to treat it. So you have to differentiate whether it is asthma or not. And at the other time, there are some diseases that are specifically associated with the pregnancy, which can mimic asthma. One such disease is heart disease. Previous heart diseases like valvular stenosis, that means narrowing of the valves of the heart, dysfunction of the heart muscle, we call it peripartum cardiomyopathy, certain muscle dysfunctions of the heart might give similar symptoms that might mimic asthma. So that is very important. So underdiagnosis, undertreatment is harmful. At the same time, you have to know exactly what you have, go to a proper doctor, get yourself investigated properly, and then start on the correct treatment.
I think now what I got from that point that we were talking about was how important is to understand what the disease is before treating it.
Yes.
So what is your thoughts on self-diagnosis? Because I think there are a lot of pundits out there, if I may, who tries to be the doctor at their own homes. So what is your message to those people? I mean, it's not very safe, right, to diagnose the disease that you are having without the proper medical doctor. So what's your thoughts on that?
Now, to be honest, I think each and every one of us has the right to make a decision about your life. So that is what we call autonomy. So if I diagnosed asthma in you, and you will help me refuse the inhaler for whatever the reason, you have the complete right of doing that, provided that you understand the gravity of refusing. right? So then that is no problem about it. So now it is, I think it is very important to understand the disease, and I actually promote my patients to read about asthma, but the things that you read should be scientifically based, not hearsay. So if you read scientifically based articles or factual articles, now there are actually patient leaflets from the American Thoracic Society, British Thoracic Society, various professional organizations. They have professional patient leaflets that is they are free to download in the internet, and you can read them at your leisure. So if you read this correct material, then I think you will get the correct picture. But if you go for hearsay, and if you read about the Facebook articles about, you know, various type of things that are there and the harmful effects, I think you are doing yourself a more harm than good. So we are educated people, we are intelligent people. So we should know, we should be able to define what is true and what is factual and what is false. So having a correct source of information and looking at that source, I think one source is like this, the education from the media. So if you have a correct source of information and if you can understand about your disease, I think you will never ever, you know, go down that pathway and self-diagnose and then do things in your own, hopefully, because it's a very complicated disease and you might need help in managing your treatment.
Exactly. And now we did mention in the beginning that we did celebrate the World Asthma Day. It was, to be precise, it was the 3rd of May this year, but usually it's the first Tuesday in the month of May. So the theme for this year was closing gaps in asthma care. Now we did talk about that in a previous segment, but I just wanted to discuss about the current gaps in Sri Lanka or worldwide as well. What are the current gaps in asthma care in the current situation?
You know, it is really unfortunate when you think about the asthma situation in certain parts of Sri Lanka, even in Colombo. I will give you a highlight that I usually highlight in my lectures. This child was came to me when I was working in the Padulla. 13-year-old female child, girl child, who was rather depressed, not looking at the eyes, and she was having recurrent attacks of wheezing, cough. Mother and his brother also had wheezing and cough. Father was working in a brick burning facility. He was smoking at home as well, and she has to go to the doctor every 2 to 3 weeks. She has to cut her school because of that, and now she's bedwetting. That means she's wetting her bed. 13-year-old female child. Now, obviously, this child is having asthma, and unfortunately, the medical personnel that the patient has been seeing has not diagnosed the patient properly, and has not started the proper treatment on this child. And as a result, this child is suffering in a physical way. She has not grown appropriately. And she is not actually, psychologically she is suffering, she is bedwetting, she is probably depressed, and she is not being able to go to school. We don't know whether she might be the next professor of medicine in the Faculty of Medicine, Colombo, if he was properly, you know, nurtured, but we don't know that. But she has not gone to, she is not able to go to the school, and at the same time she can't go and play with the children, other children, and because of that her personality is suffering. So you can understand that. So that's a major gap, you know. Some of the peripheral, or even in Colombo, our medical profession is at fault for not diagnosing asthma properly to a certain extent and not prescribing the correct treatment. So that is one gap that we have to address, and we are trying to address that gap as much as possible. The second gap is that even when the patient is properly diagnosed and initiated on treatment, there is a huge reluctance to accept that you have asthma, because of the stigma associated with that. Especially if you tell a girl, adolescent girl, that you have asthma, and the mother, you can see the sudden change of the face expression of the mother, right? And if there was a grandmother, you can see that sudden change, because they think that, okay, this child will never be able to have a job, study, or marry.
Basically a normal life.
Yeah. Or never will be able to have a normal life or marry. Earlier there was a little bit of a problem like that. If you have asthma, probably you might have a difficulty in getting a decent proposal as well, because if you are taking an inhaler, but now things have improved in certain parts of the country. So this myth of asthma, of saying that asthma is not a bad disease, it is a disease that we can control completely. So that message, I think, should be gone to the public. And the third thing is about the treatment of asthma. So there's another gap, right? So if you can convince the patients to get treatment, proper treatment, without hindrance, without getting fearful about the side effects and other problems, I think we can achieve a lot in Sri Lanka. So to tell you the truth, when you talk about asthma, any disease has its severity forms, right? But even when you think about 100 patients with asthma, at least 96 of them can be completely controlled if we take the proper treatment, and only 4% might need elevated, that means enhanced investigations and treatment options in the current world. Only 4, right? So 96 of them most likely will be able to control. But unfortunately, when you take the asthma population, about 50% of them are suffering without any underlying reason, and I think that is a major gap that we have to address.
I think those were some gaps which should be addressed,
yes.
And you are on a mission to
yes.
address those as well. I think, Doctor, thank you so much again, because we have come to the latter part of the program, and for explaining the gaps, because Sri Lankans usually are not well informed about these topics,
yes.
in the current context as well. So we did have with us the consultant pulmonologist at the teaching hospital and district chest clinic in Ratnapura, Dr. Niranjan Disanayake, with us. So thank you so much, Doctor, because we did talk a lot on asthma and its related aspects, the socio-economic relations, the correlation with the physiology of a child, and much more, starting from the pregnancy and much more. So thank you so much, Doctor, for allocating the time out of your busy schedule and being here in an attempt to educate the public.
Thank you very much. It's a huge pleasure. Thank you.
The pleasure's ours, Doctor. And with that, we wind up today's segment of iMed. Thank you so much for joining in, and hope to see you next week, same time, same place on Channel I. So with that being said, it's goodbye from me. Have a pleasant day ahead.